All right, can everybody hear me?
Yes.
Yes.
Professor.
Yes.
All right, so let's begin. Don't be intimidated by chapter 34. Let me just emphasize that this class, though, this is not a cardiac rhythm class. Cardiac rhythm class usually takes several weeks for an RN. Even somebody studying to get their telemetry license, let's say you want to be a telemonitor tech, that is another 3-day class. So we have 3 hours to do this. And plus that 3-day class includes homework before you attend the class. So this is simply basic rhythm interpretation. To be fair, the examination strips that I'll be using will be based only off of your textbook. So the actual pictures shown on chapter 34 and chapter 38 will be the only strips that you will see on your exam. Fair enough?
Yeah.
Yes.
Okay, before we start, let me explain for the exam. All you're tested on are the following. First is recognizing the strip. Can you see my whiteboard? Probably not. No?
No. No, sir.
Um,
Yeah, no, we can't see it.
all right, can you see it now?
Yep.
Yes.
All right. Can you see it now?
Yeah.
Yes.
Okay.
Yes.
Recognize the strip again. So you'll see some questions will simply be asking you, so what is this rhythm? All right. Of course, the other question will be beyond that. Other questions will not only stop at recognizing the strip, but also asking you either an assessment, meaning the patient, what will be the patient's signs and symptoms, or simply what will you do next, or what will you do first. So first is recognition. Next are the causes. Not all dysrhythmias are necessarily need treatment or require treatment. The treatment will always be based on the patient's symptoms. Some dysrhythmias are, especially sinus dysrhythmias, are harmless. Heart blocks, for instance, first degree heart block, do not require intervention. So we need to know the cause so that we can try to eliminate the cause, and that will be simply your treatment. So no drugs necessary. You simply need to identify what's possibly causing the dysrhythmia, eliminate it if you can, and that is your only action. Next are signs and symptoms. Regardless of the dysrhythmia, they all cause decreased cardiac output. The severity varies. Sinus dysrhythmias typically don't cause any symptoms at all, meaning they do not affect cardiac output. So therefore, will there be signs and symptoms?
No.
Yeah.
No. All right. Most signs and symptoms are similar simply because what is the body's response again whenever there is low cardiac output, low oxygen, low blood volume?
Increase output.
All right, so automatically that will trigger the epinephrine or norepinephrine release. So the symptoms will be similar. Okay, so we'll go through the signs and symptoms of any bradydysrhythmia as well as any tachydysrhythmia. They will again share the same signs and symptoms because they all cause what again? They all cause. Can you mute yourselves, please? Thank you. So, what is the signs and symptoms? Whenever,
Decreased cardiac output.
yeah. So, what are those? I mean, the exam question won't show you, won't say decreased cardiac output. So, what are those signs and symptoms of decreased cardiac output? Will there be lightheadedness? Hello?
Yeah, your lecture keeps breaking up, sir. That's not for you.
Okay, so I'll continue. Signs and symptoms. Next are interventions. Interventions will be pharmacologic as well as non-pharmacologic interventions. Some dysrhythmias will require surgical intervention. And then finally, part of your intervention is also teaching. And because you know the causes, that will also include prevention. Are you following so far?
Yes.
Okay.
Yes.
If it's surgical intervention, of course, our questions will always be, what do you do before and after the procedure? Some interventions will require that you participate, such as, for instance, cardioversion. So you will be at the bedside together with the person performing the procedure, but not all the time. Again, questions on the exam for chapter 34 related to cardiac rhythms are: number one is recognizing the cardiac strip. Next is knowing the causes, signs and symptoms next, and finally interventions. Interventions will be pharmacologic, non-pharmacologic, surgery, or let's just say invasive, or could also be invasive procedures, which will require pre and post-op, and then finally teaching. For pharmacologic, of course, the testable part here are your nursing responsibilities. What do you do? What do you assess? Responsibilities. Okay. What do you do? What do you assess before and after giving certain medications? Any questions so far?
No,
No.
Professor.
All right. All right. Okay. When you were conceived, um, let's say when Miss Javi was conceived, she was a single cell organism, right? So, long story short, her parents met. You know, her dad said to her mom, "Sup," and then they went out. And then, long story short, um, Javi was conceived. Okay, so from one single cell organism, she became the person that she is now, a very complex organism. Okay, but during fetal development, we went from one cell to two to four to 16, etc. So you can say we all came from one pluripotent stem cell. And from that one pluripotent stem cell, one of those became the cardiac system, meaning the entire heart came from one single stem cell. During differentiation, they became more specialized, okay? But at one point, they all possess similar characteristics. Cardiac muscles, cardiac cells possess these following characteristics. They have automaticity, as defined. This is, of course, the ability of cardiac cells to generate an electrical impulse. We know about action potential, right? Action potential, meaning that the heart can generate its own signals. It does not require nerve stimulation, just like skeletal muscles do. Skeletal muscles require nerve stimulation before they can function. So that's why that will explain why when you have a spinal cord injury, you become paralyzed. Technically, your muscles were fine, but without any nerve impulses to stimulate them, they become useless. That's not true for the heart. The heart is independent of nerve stimulation, it can generate its own. It does not depend on the brain or any other organ in order to function, although it can be influenced by the brain. Another is excitability. Excitability meaning each cell in the heart can be excited by those nerve impulses coming from its own, coming from itself. Conductivity meaning they can conduct that electrical impulse generated in this instance coming from the SA node, which is our primary pacemaker. Okay, so each cell in the body can conduct that. However, contractility, just like automaticity, these are functions or characteristics that are possessed by specific cells only in the heart. For instance, pacemaker cells do not contract. Okay, they possess more pacing functions or automaticity. In the same way, other cells in the heart, which are not involved as pacemakers, should not generate pacemaker functions, meaning they should not produce electrical impulses. They can be excited by them, they can conduct them, but they do not generate the electrical impulses. And only myocardial cells have the ability to contract. All right, meaning at one point during development, all of those cells possess characteristics. As we mature, though, as the heart developed, as the heart was forming, they became more specialized. As we age, most of us will have cardiac dysfunction, meaning we're talking about a 80-year-old heart, a 90-year-old heart. Okay, so as we age, certain characteristics are possessed by some cells which they shouldn't be. Okay, one such example is atrial fibrillation. Although aging isn't the only cause, but that's one example. Now, as we grow old, some cells start doing or performing functions that they shouldn't be doing. Are you clear so far? Any questions?
Yeah.
Okay.
No.
Yes. Clear.
Is yes or no?
Yeah, we're good so far.
Okay.
Clear.
Any question?
No.
No question.
All right. So let's discuss this figure right here, figure 34. All right. So this is the electrical conduction path of your heart. Our primary pacemaker is the SA node. We have a secondary, which is the AV node. And then the third set of pacemakers are connected to the AV node. They are the right and left bundle branches. And then finally, the Purkinje fibers. Okay, so your textbook will say that the intrinsic rate of the SA node, meaning if the signal is coming from the SA node, it can fire. The rate will be 60 to 100 beats a minute because it can fire 60 to 100 times per minute. You will know that the heartbeat or the electrical impulse is generated by the SA node if you see a P wave. So this is the P wave. The P wave represents atrial depolarization, meaning atrial contraction. So as the SA node generates the electrical impulse, it will be spread through the interatrial branches, which is not shown here, allowing both atria to contract at the same time. So that both are represented by the P wave. Now, I mean, you've seen lightning, right? Light up the sky. Did it take long for lightning to go from where it formed up in the clouds until it hit something?
No.
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 Right. It's almost instantaneous, right? You saw it light up and then you saw it hit something. So will it take long for the SA node signal to reach the AV node because it's an electrical impulse?
Yeah.
No.
No.
No. So it will reach it instantaneously. However, the AV node will not transmit that electrical impulse right away. It will delay transmitting it, meaning it receives it, but it chooses not to transmit it right away. So it will delay transmission of that signal by 0.12 to 0.2 seconds. So this is less than a second. Now, this short delay is necessary because imagine if the signal electrical impulse goes from the SA node straight here and then straight down here. What will happen to the timing of the contractions? Will there be a lub-dub sound, or will you just hear one sound?
One sound.
One sound. That means if there is no delay, that means as soon as the atria contract, the ventricles will also contract at the same time, right?
Yes.
Yes.
Do we want that happening though?
No.
No.
Atria should contract first, fill the blood in the ventricles, meaning there's blood in the atria. As after they contract, they pass that blood into both ventricles before the ventricles contract. So is that delay necessary?
Yes. Yes.
It is a very crucial delay. That delay is represented by your PR interval. We measure the PR interval from the P wave right here up until it leaves the isoelectric line. I forgot to mention the isoelectric line. Okay, let's go back to your textbook. All right, so you see my textbook? Okay, on the EKG paper, let's use this one. All right, as you can see, the waves and complexes do not really fall on a solid line, right? Yes or no?
Yeah.
They don't. Okay, so there's an imaginary line there from which each wave, let's say the P wave, rises and falls back. You see it? Okay, so the P wave here starts from here and then ends here, right? And then this one also starts here and then ends here, meaning there's an imaginary straight line from which all the waves and complexes rises and falls from. You understand what I'm saying? Hello?
Not really.
Yeah.
Not really. Okay. So let's say there's this imaginary line here. You see how this P wave left that imaginary straight line, rose up, and then fell back into it before it proceeded to form another complex?
Yeah.
Okay. So
Yeah.
there's an imaginary straight line somewhere along here, and that is called the isoelectric line. ISO meaning I spelled ISO, ISO, and then electric. Okay, isoelectric line represents a period of no electrical activity. Okay, so The PR interval is measured from the time the P wave formed from where the P wave left the isoelectric line to right before, which will include the entire P wave, until right before the QRS complex begins. Time here, I'll show you later how to measure it. So this is the PR interval right here. Don't ask me why they call it the PR, because the R wave is right here. So the PR interval really has nothing to do with the R wave. You understand?
Yeah.
So don't be confused when you say PR interval has nothing to do with the the R wave, okay? That's just a term they call it. So again, the PR interval is measured from the P wave, from the start of the P wave to right before the QRS begins. What is the significance again of the PR interval? This is the time.
The delay.
Okay, this is the time of the delay where the AV node delayed the impulse. Meaning the SA node generated the electrical impulse, causing both atria to contract, forming the P wave, and then the time delay for that same electrical impulse to reach the AV node, which it did reach it instantaneously, but this is the time that the AV node held on to that impulse before it transmitted it down to the left and right bundle branches down to the Purkinje fibers. All right. So this is now the next, the phase of the cardiac cycle is now ventricular contraction. So the electrical impulse now reached the AV node. The AV node delayed transmission for 0.12 to 0.2 seconds, and then it transmitted the signal down now to the left and right um, bundle branches, and then into the ventricles, forming the QRS complex. So the QRS complex therefore represents ventricular contraction or ventricular depolarization. And then there is another short delay here. I mean, a short period wherein there is no electrical activity happening in the heart. So you can say this is early ventricular repolarization. And then the T wave here represents ventricular repolarization. And if you go back to ANP, this is the time when the cells become more positively charged now. Okay, but here there is no electrical activity here. So in the T wave, the because after discharging here, after the ventricles contracted or depolarized, of course, that will make each cell in the ventricles more negatively charged, right? After it depolarized. So the T wave represents the time wherein it's becoming more positively charged again. And it reaches a point wherein it's so positively charged, so much energy in there, it will discharge again at the next heartbeat, the next ventricular contraction. Questions so far about what the
I have a question.
is about?
You said the QRS complex was ventricular contraction and ventricular depolarization?
It's the same term. You can choose either to say ventricular contraction or ventricular depolarization.
Okay. And then the T wave was the repolarization?
Yes, meaning they're getting ready for the next contraction.
Okay. What?
No.
Any other question? Anna?
It
Going
keeps
back?
breaking up, so it's hard for me to
Okay.
understand, but I'm doing my best.
What's your question, Ashley?
Nothing yet.
All right. So anybody have a question of why these waves and complexes are formed? So again, to recap, So the SA node fires or generates the electrical impulse, forming the P wave, at which point the atria are contracting. And then that same electrical impulse hit the AV node. However, as you can see, it did not occur instantaneously. There is a delay before the electrical impulse was transmitted to the left and right bundle branches, representing the PR interval. And then finally, the electrical impulse was transmitted down, forming the QRS complex, meaning as soon as the electrical impulse traveled down the left and right bundle branches and the Purkinje fibers, the ventricles contracted, forming the QRS complex. And then they rested right here. So the ST segment represents there should be no electrical activity here because the ventricles just fired. And then finally, it will begin repolarizing again, getting ready for the next ventricular contraction. So the T wave represents the time that there is now still electrical activity starting at the ventricles, but they're not as high as during contraction. So if there is ventricular depolarization and then there's also ventricular repolarization, wouldn't the atria do the same? Because before the atria can depolarize, it has to repolarize somewhere, correct?
Yeah.
Okay, do you want to ask where the atrial repolarization
Yeah.
happens?
Yeah, where does it happen?
I have no idea.
Well, I think during the repolarization occurs during the QoS.
Yeah, that's a very good theory, but until somebody proves it, um, no, we don't really know because there is no such representation. We know it happens, right? It has to happen because I mean it can't depolarize unless it was able to repolarize as well. So the answer really is we have no idea where exactly it repolarizes. We know it has to repolarize sometime. Okay, but because of the electrical activity during the ventricular contraction and ventricular repolarization, we have no idea where exactly the atria repolarize. All right.
Okay.
All right. We still have 4 minutes before we end. Let me just finish up a little bit before we start with rhythm interpretation. So again, to recap, the baseline is the isoelectric line, and I showed the concept, meaning this is an imaginary line from which positive and negative deflections lead and form. Um, I won't discuss the entire 12 lead EKG system. I mean, it'll take us a long time. I'll go straight to what does a EKG paper show. All right. And then after I explain this, we'll take a break because we're out of time anyway. So this is a typical EKG paper. It has vertical lines, it has horizontal lines. It has small boxes, as you can see, and there are also big boxes. Okay. The vertical axis represents voltage. Know how much electrical activity is. This is measuring electrical activity or voltage. The horizontal axis is time in seconds. There is a enlargement here of a big box. As you can see, a big box or a big block has 25 small blocks inside it. It means it has 5 vertical small blocks. There are also 5 horizontal small blocks. So we said that the horizontal axis represents time in seconds. So one small box is 0.04 seconds. And one big block, because this is 0.04 times 5 equals 0.2 seconds. Again, let me recap. The horizontal line is representing time in seconds, and one tiny block, one small block measures horizontally is measured 0.04 seconds. So that means if there are 5 of them in one big block therefore represents 0.2 seconds. Clear as mud or clear as crystal?
Crystal clear.
Professor, what did you say when there's 5 boxes? It's 5 times 0.04?
Equals 0.2 seconds. All right.
Okay.
Okay. Okay, it's time for a break now. We will return at 6.
Wait, sorry, quick question. So even though you said there's 25 like boxes, it's only the whole thing itself represents 20 seconds.
No, it's not 20 seconds. Again, only the horizontal line measures time in seconds. The vertical measures electrical activity or voltage. So for time purposes, we're really measuring only the horizontal line.
Okay.
Okay. All right. I'll sign out. I'll see you at 6:50.
Okay.
All right. I'll see
Okay.
you back at 6:50.
Okay, Professor.